So thank you to Dr. Deneve for being here this afternoon to share his expertise on peritoneal carcinomatosis, the good, the bad, and the ugly. So Dr. Deneve comes to us. He is a new surgical oncologist, new to UNC. Are you still technically new? He manages and treats complex GI and skin soft tissue malignancies, as well as performs HIPEC. He participates in clinical trial enrollment with the Southwest Oncology Group. He is board certified by the American Board of Surgery in general surgery, and in his spare time enjoys reading, history, triathlons, and Alabama football. So how often are you engaging in triathlons?
Yeah, it's kind of a hobby and probably more a stress reliever than anything else. I've done several Olympic and half Ironman, and I've actually done 5 full distance Ironman races. So we're training for later this summer, so we'll see how it goes. So,
oh, that's great. So here is a sample of what Poll Everywhere will look like. Our first sample question is cytoreductive surgery and hypothermic intraperitoneal chemotherapy are used in combination to treat peritoneal metastases. True or false? So you can go to Poll Everywhere and test out and answer the question, and we will circle back to it in a minute. Here are our disclosures. And here you can go into Poll Everywhere to respond to our first sample question to make sure your Poll Everywhere is working. We will give everyone a minute to get set up.
hint, hint, it's the top answer.
I was going to say, I'm going to answer true. All right, so
we'll see answers there.
Yeah, we're getting some answers.
Thank you.
So I will turn it over to Dr. Deneve. Thank you.
Great. Well, Tammy, thank you so much for the kind, warm introduction and the opportunity to come to you and present today. I certainly appreciate it. I am relatively new, I would say. I've been here a little less than a year, just almost right at a year. And most recently from the University of Tennessee in Memphis. And while I have trained and lived all over, happy to call North Carolina home, and it's an honor to be with you today. So thanks for giving me a few minutes out of your Wednesday afternoon to come and hopefully inform and educate on a topic that I feel pretty passionate about. And I think tried to give a little catchy title to maybe persuade you to want to join us today. Peritoneal carcinomatosis, the good, the bad, and the ugly. Had you told me when I was in training or even a resident or fellow that this would be what my practice ultimately would become, I certainly would never have thought it. But here we are, and this is part of the reason that I was actually recruited to the University of North Carolina. So I appreciate the opportunity to speak. I have no disclosures. A couple questions, so pull out your phones, and we'll go back to Poll Everywhere. I'll read through these, and then we will discuss these at the end as well, but feel free to answer now, and then we'll circle back around to see how well we did. Peritoneal carcinomatosis is an aggressive form of disease spread and characterized by the following manifestations: advanced disease at onset, malnutrition, malignant ascites, progression to malignant obstruction, all of the above. Next question. Recommended treatment for malignant related ascites includes all of the following treatments except diuretics, HIPEC, hyperthermic intraperitoneal chemotherapy, paracentesis, HIPEC, pressurized intraperitoneal chemotherapy, or a PV shunt, portovenous shunt. Okay, good. We've got several interesting answers, so hopefully we can shed some light on this topic. And then last question. Cytoreduction and hyperthermic intraperitoneal chemotherapy offers a potential cure for peritoneal carcinomatosis. HIPEC is characterized by all of the following except heat is synergistic with chemotherapy. HIPEC offers high regional concentration of chemotherapy with low systemic toxicity. It has a maximum tissue penetration of 3 to 5 millimeters. It has a short learning curve with low morbidity. It should be performed at high volume centers. Okay, we'll move on to the talk, and then we'll see how we did at the end of the presentation. Peritoneal carcinomatosis, I really just wanted to go through some of the big picture items as it related to this and really inform as well. Some of you maybe see this from time to time throughout your practices. Some of you very rarely at all. Hopefully this will be educational, informative for all of us today. So we'll talk about the background, some of the pertinent anatomy and pathophysiology of how carcinomatosis develops, current treatment for carcinomatosis, as well as what to do in situations where there's high volume disease. I chose the title Good, Bad, and Ugly. Some of you may have seen this old spaghetti Western. It was released in the 1960s. Clint Eastwood, this really put him on the map as far as a Western-themed actor as well, and certainly an interesting story for those who haven't seen it before. I'd highly recommend. The natural history of carcinomatosis is actually pretty ominous and pretty dismal. Unfortunately, these patients oftentimes present with malignant ascites or even in advanced stages with malnutrition, and eventually can go on to develop malignant obstruction, even with local tumor growth as well. The prognosis, unfortunately, is rather poor. Many of these patients go on to die of their disease with very short survivals, as short as 5 months. Which improves a little bit with palliative therapy, but is still, unfortunately, rather poor. We know there are several risk factors, in particular for GI malignancies, those who present with locally advanced tumors, T4 tumors, those that grow into other structures, certain histologies in particular, mucinous adenocarcinoma, typically involving the right colon, signet ring cell pathology, whether it's from gastric origin or from colon or appendiceal origin, tumors that present with perforation, those with advanced nodal stage, or those that undergo incomplete resection with margin-positive resections are all risk factors for carcinomatosis. Peritoneal surface malignancies can develop from a variety of different histologies. The appendix, the colon, the ovary are probably the most common. In rare cases, mesothelioma affects probably around 500 patients a year. Gastric cancer is a known risk factor for development of peritoneal surface malignancies, as well as rare sarcoma subtypes as well. This is an interesting study. It's a little bit older, but I still think relevant as well. Published in Cancer in 2000, this was a French group and actually a very high volume center in France that routinely performs HIPEC, and will present some of their data a little bit later as well. But really looking at the natural history of the development of carcinomatosis from a variety of malignancies. This table just demonstrates several of those malignancies and their stage of presentation at the time of their carcinomatosis diagnosis. I just wanted to hone in briefly on the colorectal pathology. It had 118 patients out of their 370 in this cohort. Interestingly, 60% of these patients presented with sequenced disease, meaning carcinomatosis present at the time of diagnosis. A third presented with malignant ascites, 20% presented with bowel obstructions. About 3/4 of the patients underwent surgery, and in a quarter of those, bypass was the only procedure they were able to undergo. Unfortunately, only a small percentage of these patients, 40%, were able to undergo treatment with palliative chemotherapy. And as you can see here, the median overall survival is actually pretty poor. This is a real problem that we see regularly in our practice, and I think that the more we educate ourselves, the more we could potentially offer some sort of relief to these patients. The difficulty that we often encounter is these patients often present with very late onset of disease. Many are symptomatic. They present with ascites and malnutrition, as we discussed previously. The natural history is for them to go on to develop malignant obstructions, which can be very difficult to manage. Radiographically, these are difficult to identify. Here's an image taken from a diagnostic laparoscopy where you can see small miliary little tumor spreads, almost look like little snowflakes on the lining of the abdominal cavity on the peritoneum. This unfortunately isn't visible on standard CT scan imaging when disease presents in this small nature, but certainly this is pretty extensive disease. The difficulty that these patients face is that oftentimes this is a pattern of recurrent disease as well. Oftentimes patients have been treated with multiple lines of systemic chemotherapy. Oftentimes they have a declining performance status, and unfortunately extensive disease or large volume disease makes many of these patients not suitable surgery candidates. This is a standard CT scan finding for somebody we would evaluate in clinic. You can see in the image on the left, the rim of ascites around the liver and the spleen. In the image on the right, if you can envision just below the rectus muscle, there's evidence of omental caking as well, and we'll show you some images of what this looks like in real time. But this is standard findings for a patient with carcinomatosis. At diagnostic laparoscopy, we examine all quadrants of the abdominal cavity. These are two representative images of the right upper quadrant and left upper quadrant. And again, you'll notice the plaque-like tumor implants. And again, these aren't visible on radiographic images, but these images were taken from the CT scan of the patient we just demonstrated beforehand. These are images down in the pelvis. And what I'd like to highlight are, again, you see these stalactites, these small little plaque-like tumor implants scattered across the entire lining of the parietal peritoneum. Down in the right image at the bottom, the small bowel serosa and mesentery are both involved, even though it may not project very well. But this patient ultimately has high volume disease and unfortunately is not a suitable surgery candidate and has limited treatment options. The reason why we see certain areas within the abdominal cavity that typically tend to be involved are partly because of the relationship of the anatomical organs as well as the distribution of lymphatic flow within the abdominal cavity. These are netter images taken demonstrating the gastrocolic ligament and the greater omentum, again, a very common site of disease spread. In the image on the left, you see the small intestine's been removed and you see the root of the mesentery, and the two images on the right demonstrate sagittal sections of both the female pelvis and the male pelvis. Drop metastases are common as well, with disease often involving the pelvis of males and females. During normal inspiration and expiration, diaphragmatic excursion creates this pressure gradient between the thoracic cavity as well as the abdominal cavity. What ends up resulting is this clockwise lymphatic flow pattern within the abdominal cavity. And if you can see in the image of the left, the arrows pointing up along the right side of the patient's abdomen, along the pericolic gutter, and ultimately to the liver as well, you get this clockwise flow of lymphatic fluid during normal respiration. The image on the right, you see the falciform ligament up at the top, the phrenocholic ligament as well in the left upper quadrant. These two physiologic ligaments serve as natural barriers to lymphatic flow. So at the time of diagnostic laparoscopy, it's very common to see disease involving the right diaphragm, less so common to see disease involving the left diaphragm unless there's really significant disease. And this is something that we see on almost a weekly basis. The omentum has these particular areas that makes it a unique area for carcinomatosis development as well, and which ultimately results in omental caking. There's an accumulation of lymphocytes and macrophages as well as these highly vascular areas referred to as milky spots. What these basically do are to clear, bacteria and different particles from the abdominal cavity kind of as a normal kind of homeostasis mechanism. Unfortunately, it's a common site for tumor implantation as well. And as tumor cells spread throughout the peritoneal fluid, cancer cells oftentimes will implant in these milky spots and then ultimately grow. The peritoneum is lined by a mesothelial cell. This is the structural cell of the parietal peritoneum. It originates originally from the mesoderm. When intact, it's an excellent barrier to infection and or disease spread. However, as tumors infiltrate and or if there's any sort of surgery or inflammation or injury to the mesothelium, ultimately you have exposure of the extracellular matrix. Tumor cells can ultimately then implant overtake these mesothelial cells and then grow. Tumor cells will grow oftentimes transversely. If you think of like a forest fire spreading along a field of wheat, or you can have further exfoliation of these tumor cells and further intraperitoneal spread. The development of carcinomatosis is a complex process, one in which tumor cells just detach from a primary tumor, float around, and ultimately attach wherever they land. They ultimately then invade the mesothelial cells, grow and proliferate, and ultimately induce these angiogenic factors to ultimately recruit blood supply as they continue to grow and develop. Cytoreduction and HIPEC, hyperthermic intraperitoneal chemotherapy, have over the last 20 years really been popularized as a potential cure and treatment for selected patients with carcinomatosis, and that's what I wanted to talk to you some about today. Cytoreduction refers to the aggressive surgical removal or resection of all visible disease. HIPEC refers to the chemical destruction of any microscopic disease. It's essentially a localized regional therapy confined to the abdominal cavity. We're able to give a much higher dose than we're able to give systemically with limited absorption. We calculate how well we do from a surgical standpoint by determining things such as the PCI score, the CCR score, which I'll talk about, both of which have been correlated with improved survival. As far as the surgery details itself, it involves performing a laparotomy. We make a pretty large incision from the xiphoid all the way down to the pubis and address the areas that are often the most difficult to address first. Typically, this ends up being the pelvis or the diaphragm. We remove all disease sites and then perform a selective peritonectomy, removing those areas where we see disease. If there isn't disease, we leave it alone and we don't remove all of the peritoneum unless all of the peritoneum is involved. HIPEC is performed after surgery, and then after the completion of HIPEC, we reconnect anything that needs to be reconnected, create any stomas or ostomies that need to be created, and then the patient's taken to recovery room. These are open procedures. Very rarely do we do these laparoscopically or robotically. Oftentimes, there's quite a bit of ascites present, and frequently patients have had multiple operations in the past, so we have to perform pretty complex adhesiolysis to take down all the scar tissue. This is important for a couple of different reasons. Tumor cells oftentimes will end up hiding within the scar tissue. We also want the chemotherapy to fully immerse and bathe all areas of the abdominal cavity as well. We calculate the PCI and CCR score after we take down all the adhesions and define the full extent of peritoneal disease. We remove oftentimes the pelvis and pelvic peritoneum if they're involved. This often requires removal of both the rectum and or uterus in the female, or the rectum alone if it's a male. The right diaphragm I mentioned is more frequently involved than the left, but in severe cases, both diaphragms have to be stripped of disease. The omentum is taken whether it's involved or not, simply because it's such a common area for disease recurrence. Oftentimes, we do have to remove a segment of colon and or small bowel mesentery, again, based on depending on where the disease is involved. This is a schematic demonstrating the peritoneal cancer index score. We calculate the burden of disease within the abdominal cavity by dividing the abdominal cavity into 9 different quadrants, and then the intestines into 4 different quadrants, 13 total. Each quadrant's given a number ranging from 0 to 3. 0 would be no visible disease. 3 would be disease that's either 5 centimeters or greater, or tumor confluence. If you think back to those diagnostic laparoscopy images I showed you with the CAT scan and then the kind of plaque-like tumors that were growing together, that would be confluent disease. So that would be given a score of 3. Scores range anywhere from 0 to 39. 0 would be great. 39 is obviously a lot of disease. In general, for appendix pathology, there's no PCI cutoff. We will proceed with surgery and proceed with HIPEC, irrespective of the PCI score. For colon pathology, generally a PCI score of 20 or less is recommended on a case-by-case basis. The completeness of cytoreduction score is essentially the surgical grade we give ourselves after we remove all visible disease. Our goal is to perform a CC0 or CC1 resection. We hope to have no visible disease remaining after we've removed everything we safely can. Even if we can get down to sub-centimeter and just 1 to 2 millimeter tumor nodules, we still consider this acceptable because we know that HIPEC will be administered and does have efficacy for small tumor nodules. In the setting of larger, bulky residual disease, a CC2 or a CC3 score, we consider this an incomplete cytoreduction and try not to perform this if we can avoid it. This is a 2 intraoperative images taken of some of the typical mucinous ascites that we would observe, whether it's ovarian, appendiceal, which is what this particular patient was, or colorectal pathology. Oftentimes, there's several liters of this that need to be evacuated before we can actually start. If any of you have seen the original Ghostbusters with Dan Aykroyd, and it's almost like the slime that you would anticipate, and it is very slippery as well, but something we commonly encounter. This is what omental caking looks like in real time. And if you can appreciate, there's actually tumor completely overtaking the omentum. We're lifting it up. The head is towards the top of the screen, and you can see the resident here holding the omentum with their hands. This is gelatinous tumor. This is an appendiceal tumor that was resected, but not uncommon for the omentum to be completely overtaken with tumor. Small bowel serosa and small bowel mesentery nodules oftentimes are very difficult to see radiographically with CT or MRI imaging. We are able to observe this with diagnostic laparoscopy. If we're going to perform an incomplete cytoreduction, this is typically why that happens. There's too much disease involving the small intestine, serosa or mesentery to adequately clear their disease. We clear as much as we safely can and administer HIPEC, but if we perform incomplete cytoreduction, this is why. This is a intraoperative image of what removal of the pelvic peritoneum with the uterus in the female and a portion of the rectum, which are behind, looks like. And oftentimes we remove the specimen en bloc as one really large specimen. This is another schematic from a different patient, again, demonstrating a portion of the rectum, the uterus with tubes and ovaries both involved as well. So the dissection looks all nice and pristine here, but in actuality is actually pretty time consuming and pretty difficult to do. They get a little bit easier the more you've done, but they're still challenging every single time. This is what it looks like when we strip the diaphragm. You can see the liver demonstrated. We're looking from the foot of the patient towards the head of the bed. The assistant is holding the diaphragm that we're basically stripped off of the underlying muscle, and it's a thin layer of peritoneum, and you can see just multiple small tumor plaques as well. I explain this to patients. This is akin to stripping wallpaper off of a bathroom. If you're remodeling, it's almost the exact same technique. There just happens to be multiple really important organs that we need to preserve and work around as well. And again, when removed, you can see these plaque-like, kind of sheet-like specimens that are resultant from these particular tumors. And if done correctly, you can see a surgeon here holding the liver up out of the view. That's the right kidney and right diaphragm, which you can visualize, as well as Gerota's fascia at the bottom of the picture as well. I would love to say that all my photos are taken without blood, but unfortunately that's not the case. But this is a nice schematic of what it should look like after you perform the peritonectomy procedure. This schematic here just demonstrates what roughly things look like. We take patients to the operating room. Patients are induced. They undergo the cytoreductive portion of the operation, and then we administer intraperitoneal chemotherapy. After HIPEC is performed, we then reconstruct. We put together anything that needs to be reconnected, small intestine to colon, colon down to rectum, create any diversions that need to be created if a patient needs a diverting ileostomy or an in-colostomy. And then afterwards, the patients are managed typically in the ICU postoperatively. HIPEC. HIPEC is the administration of intraperitoneal chemotherapy. The advantage and the rationale for this is that we're able to give a very high dose of chemotherapy regionally with minimal systemic absorption, oftentimes to 10 to 20-fold increase in concentrations. We know from preclinical and basic science laboratory work from many pioneers prior to me that tissue penetration typically is maximal within 3 to 5 millimeters. We also heat the chemotherapy as well to a target temperature of 40 to 42 degrees Celsius. We know that this is synergistic with the chemotherapy and has additional tumoricidal effects that ends up being about 107 to 108 degrees Fahrenheit. This is what it looks like. Catheters are placed within the abdominal cavity, connected to a roller pump as well as a heat exchanger. There are multiple commercially available methods out there to deliver an intraperitoneal chemotherapy. And there are multiple different techniques as well. The technique on the left, where you see the catheters in the top and bottom of the image and the abdomen closed with the nylon sutures, called a closed technique. That's what we perform here at UNC and what most of the centers here in the United States perform. The technique on the right, where the surgeon is actually manipulating the intestinal contents with the chemotherapy. They're double gloved and double gowned as well. That's called the Coliseum or open technique. That was popularized by Sugar Baker, who is now since retired and has been done traditionally in Europe, although many in Europe are also switching to the closed technique as well, primarily to avoid heat loss, but also as well to just minimize exposure to the chemotherapy and splashing and so forth. Multiple different agents are currently commercially available. The top three, mitomycin C, oxaliplatin, and cisplatin, are probably the most common that we use, and certainly the three that we most commonly use at this center. Mitomycin C has been around forever. It's pretty much the backbone of most of what we perform, certainly for appendiceal and colorectal malignancies. It binds with DNA and ultimately inhibits DNA synthesis. It's dose dependent, meaning that as you administer the chemotherapy with increasing time, the intraperitoneal concentration decreases and the plasma concentration increases. With split dosing, however, it mitigates the plasma concentration increasing and allows us to keep a higher dose within the peritoneal cavity. It's pretty well tolerated. The main side effect is bone marrow toxicity, which is typically seen 2 to 3 weeks after the fact. Doing over several hundred of these procedures, I've had one patient where we've actually had to give them something to support their neutropenia. For the most part, it's pretty well tolerated, which is why most centers, certainly in the United States, administer mitomycin C. Oxaliplatin has historically been more commonly used in Europe, although a few centers in the United States have used it as well. It's a platinum-based neoplastic agent, and again, is the backbone for most colorectal malignancies, certainly from a systemic chemotherapy standpoint. It also inhibits DNA synthesis. The advantage of using oxaliplatin is that we're able to give a very high dose, 5 times higher than the intravenous dose, and it's got a very short half-life, so we only administer for 30 minutes, whereas mitomycin C is administered for an hour and a half. The disadvantages of oxaliplatin are that it causes some neutropenia as well and can be associated with some hemorrhage. It is often administered in a bidirectional format, with the anesthesiologist or the CRNA giving intravenous 5-FU and leucovorin at the same time we're doing intraperitoneal oxaliplatin. We publish guidelines, many of us who do this, there's not that many of us, in 2014 to standardize at least what we do here in the United States. And essentially, most of us have all agreed to proceed with mitomycin C for colorectal or appendiceal neoplasms as the preferred HIPEC agent. It's given in a total dose of 40 milligrams, but we split the dosing, 30 milligrams at time 0, an additional 10 milligrams are given at 1 hour. We perfuse for 90 minutes overall, and with a target temperature of 42 degrees Celsius. One of the things that I think is really interesting and that I have come to learn firsthand in performing these procedures is that there is a pretty significant learning curve associated with these procedures. This is probably from one of the larger centers in the United States, the University of Pittsburgh. Haroon Chowdhury and Dave Bartlett reported their series of 370 patients, a retrospective review, looking at how well they did over time amongst multiple surgeons and looking specifically at their learning curve. How well were they able to optimize and perform a complete cytoreduction, How often were they able to eventually reduce morbidity and improve outcome? This just demonstrates here, as it relates to morbidity rates and incomplete cytoreduction rates. Think of the CC2, the CC3 resections, where you're leaving pretty large volume gross disease behind. They estimated that it takes approximately 180 cases needed to ultimately improve outcomes for these patients. That's a lot of cases, and takes a while to certainly accrue to that date. When it comes to oncologic outcomes, fortunately, a few less, but still 90 cases were needed to improve oncologic outcomes. So long story short, a pretty extensive learning curve associated with these procedures. And certainly I think you benefit from having come from a place where you've been trained on these procedures. Unfortunately, for most of us who've been doing this for quite a bit of time, most of us did not have programs that we were training from where programs were implemented and or had limited exposure and fellowship. And much of what we've learned has been on-the-job training after the fact as we've kind of dedicated our practice and careers to managing these complex patients. We have attempted to set some standards as far as those who choose to do this, potentially as a portion of their career and their practice, and that fellows who do train in complex general surgical oncology fellowships should hopefully at least undergo 20 cytoreductive surgery cases, with 5 of those at least involving some portion of a diaphragm peritonectomy, 5 of those involving complex pelvic peritonectomies. Think of those large en bloc specimens that I showed you, and then 5 of those also receiving intraperitoneal chemotherapy. A few just short outcomes as far as typical pathologies we would see. This is data reported from Australia. David Morris, who is essentially the Australian HIPEC guru, demonstrating their outcomes for appendiceal neoplasms who undergo cytoreduction in HIPEC. You can see on the image Kaplan-Meier curve to the left, patients who undergo a CC0, the line in blue, or CC1 resection have a better outcome than those represented in gray, which represents the CC2 or CC3. When you look to the right, there's certainly an overall survival benefit as well to those able to undergo complete cytoreduction in HIPEC, as demonstrated in the blue. This demonstrates outcomes for patients with ovarian malignancies who are treated with neoadjuvant chemotherapy and then undergo interval cytoreduction in HIPEC. And again, there's a progression-free survival benefit and an overall survival benefit. And this has been demonstrated in multiple randomized controlled trials for ovarian cancer. As it relates to mesothelioma, one of the other pathologies we treat regularly, our very own from the state, Dr. Levine, Dr. Shin, and Dr. Vodonopoulos, Costas, reported their data for intraperitoneal mesothelioma. Again, very, very rare tumors. They treated about 110 patients over almost a 25-year period. And what you're able to demonstrate here on the Kaplan-Meier curve to the left, those that are able to undergo multiple cytoreduction and HIPEC procedures do better. Those that were perfused with cisplatin-based chemotherapy, which is the preferred HIPEC agent for mesothelioma, tend to do better as well. As it relates to colorectal cancer, there have been 2 randomized controlled trials. Dutch trial, which was reported, long-term follow-up reported in 2008, a 22-month survival for HIPEC patients, 12 months for those who undergo standard chemotherapy alone, and a 5-year overall survival of 45%. It's important to note in this study, this was pre-standard chemotherapy that we currently use. This was 5-FU and leucovorin prior to the initiation of oxaliplatin and irinotecan. Just to throw a wrench in the system, most recently, Prodige 7 was reported in 2021 and compared patients who underwent cytoreduction surgery without HIPEC to those who underwent cytoreductive surgery with HIPEC. What they observed is there was no difference in overall survival, no difference in relapse survival, meaning the administration of oxaliplatin, which was the HIPEC agent that is standard in Europe, offered no benefit. Cytoreduction, however, did have a much, much better outcome than we ever anticipated, with a 41-month overall survival for those patients. It's important to note for these patients that mitomycin C is what is standard here in the U.S., and so these results were viewed with kind of mixed opinions as to believability or not. I think the important thing to note is that this is a very good randomized controlled trial across multiple centers. We have not been able to do that here in the United States. And while we still perform HIPEC routinely for colorectal cancer using mitomycin C, I still think the French did a really good job with this. They actually came and talked at multiple of our surgical meetings after these results published and provided some really helpful commentary as well. Here's where we stand currently. This is NCCN guidelines. I took this from a different talk about 2 months ago, but it hadn't changed over the last 3 years, so I think we're still good to go. The panel currently believes that complete cytoreductive surgery and/or HIPEC can be considered in experienced centers for selected patients with limited peritoneal metastasis for who you think you can remove all visible disease, R0 resection. However, the significant morbidity and mortality associated with HIPEC, as well as the conflicting data, the PRODIGE study I just mentioned, make this approach very controversial. What we did at the same time that PRODIGE 7 reported, we ended up collectively across several U.S. institutions met for the Chicago Consensus Guidelines on Management for Patients with Peritoneal Metastases. Unfortunately, NCCN guidelines have limited recommendations. We thought it would be most appropriate to help provide some insight and guidance as to how we as cytoreductive peritoneal surface malignancy surgeons would recommend managing these complex patients. We've done this for multiple different diseases: appendix, colon, ovarian, mesothelioma, gastric, what have you. And I'm happy to provide that information to anybody should you so be interested. Multiple different research efforts are across the country, and I just listed several here. There are many more, but certainly a lot of work being done in this space. I wanted to shift gears for the last couple minutes of our speech and talk about what do we do in situations when patients aren't cytoreduction HIPEC candidates, those that maybe have been on chemotherapy but have progressed or are not tolerating, those who have high volume disease that we maybe do a laparoscopy for and don't think we can clear all their visible disease. What about those who develop refractory ascites that require frequent paracentesis or have a declining performance status? I showed you the schematic here above. Malignant ascites is something we frequently see. It develops ultimately due to lymphatic obstruction. Most of the reabsorption of ascites or the peritoneal fluid actually occurs in the subdiaphragmatic capillaries. When you have tumor confluence involving the diaphragm, these lymphatics obstruct, and ultimately you have increased capillary permeability, and patients go on to develop refractory ascites that's refractory to medical therapy. Certainly, ascites is very common in patients with end-stage liver disease. You think cirrhosis, hepatocellular carcinoma, and can be more effectively managed with diuretic therapy. Unfortunately, that's not the case for patients with carcinomatosis. Many times these patients undergo repeated paracentesis procedures, which places them at additional risk for protein-losing enteropathies, electrolyte abnormalities, as well as setting them up for secondary infections. Peritoneovenous shunts have also been recommended, where you have these catheters placed within the peritoneal cavity and then are inserted into the venous system to basically reabsorb and minimize the protein losses. The unfortunate reality, however, is patients who undergo shunt placement ultimately go on to develop pretty significant complications related to that, and morbidity and mortality rates are reported as high as 40 to 50%. These have fallen out of favor and are therefore not routinely performed. Laparoscopic HIPEC has also been recommended. It is something we've performed regularly, as well as multiple centers, and is approved for therapy as well for malignant ascites. A short case study here 58-year-old female who originally underwent resection with a right-sided colon cancer. At the time of her surgery, she had high-grade disease with signet ring cells and ascites. She ultimately ended up requiring multiple paracentesis and recurred. Her CEA was elevated, and despite adjuvant chemotherapy, developed peritoneal disease recurrence. Her liver, her lungs were clean, but she developed disease within the peritoneal cavity. So you've already seen this CT scan one time before. This was actually this patient. You can see the ascites and the omental caking, and you've seen these diagnostic laparoscopy images as well. So here you have a situation of recurrent disease limited to the peritoneal cavity, but knowing this is high-grade disease and pretty advanced, this patient unfortunately was not a surgery candidate and has limited options. The problem that we run into for these patients is these patients slip through the crack from a medical oncology standpoint. Radiation oncology would not be recommended for this. And from a surgery standpoint, I cannot clear her disease because of the amount of involvement, and in particular, the small intestine and mesenteric involvement as well. So essentially, they're unresectable. Treatment options are palliative chemotherapy or supportive care. Certainly, we'll end up sending tumor off for molecular profiling. Unfortunately, the natural history is for their disease to progress. I have an interest in these patients because oftentimes they go on to develop further symptoms. And when I followed them longitudinally, many would go on to develop malignant bowel obstructions. This ultimately allowed me to partner up with Dr. Robert Krause, who was at the University of Arizona at the time and currently is at University of Pennsylvania. He was one of the lead investigators of a SWOG study examining surgical versus non-surgical management for patients who develop malignant bowel obstruction. I expressed to him my interest in the study. We ended up developing a pretty close friendship, and were able to start accruing patients ultimately to this study. And really, this patient was this study was examining patients who developed a malignant bowel obstruction due to an intra-abdominal malignancy. Patients had to have a decent performance status and to be a surgical candidate to be included, and all were admitted to the hospital. The primary endpoint of the study was the amount of good days, meaning the amount of days that patients were out of the hospital alive and without a nasogastric tube. Really, at 13 weeks, that was the primary endpoint. Secondary endpoints were how were patients doing at 90 days. There were several additional secondary endpoints as well, including some dietary intake and so forth, quality of life metrics. You can see here, this was our accrual as we were enrolling patients. We enrolled over 200 patients. And at the University of Tennessee, which is where I previously was located, we actually put several patients onto this study. And the reason for that is we had a HIPEC center there that we had developed over the last 10 years. And at some point or another, if any of you have seen the movie Field of Dreams, there's a famous line where James Earl Jones tells Kevin Costner, if you build it, they will come, talking about building the baseball field in the middle of the cornfield. That's a great movie, by the way. If you haven't seen it, I guess I'm dating myself to a certain degree. In any event, if you build a HIPEC program, ultimately all patients come, those that are surgery candidates and those, unfortunately, that aren't surgery candidates as well. That's the reason why we ended up putting several patients onto this study. Really, what it ended up showing is that at 13 weeks, whether you had surgery for a malignant bowel obstruction or you were managed non-operatively, you both had a similar number of good days out of the hospital. It wasn't designed to show a overall survival benefit favoring one versus the other, but you can see here surgery represented in the red, non-surgical management represented in the blue. Over time, and this just only shows 90 days from registration, surgery actually does parse out to have a slight survival advantage, even though the p-value was not significant. So an interesting study, and one that we were just able to report this past year, and multiple additional studies are actually resulting as of this study as well.
We have one poll everywhere question in the middle.
Okay,
of,
great. All right, well, good. So the question then, is there a role for palliative HIPEC? So if everybody will pull their phone out, we've only got a couple more minutes left. You're doing great. We're almost there. Is there a quality of life benefit? Does it avoid the morbidity of cytoreduction? Does it minimize or delay the development of symptoms? Does it improve the tolerance of systemic chemotherapy? These are all great questions, and I would say that the hope is that all of these are potentially true. So, moving on, for sake of time, we actually looked at whether or not, while I was at the University of Tennessee, if there was a potential benefit to performing repeated laparoscopic HIPEC for patients that had high volume disease. So this is the case study that I just presented to you, the CT scan and the diagnostic laparoscopy. You've got a patient who's got recurrent disease, is on second or third line therapy, still has a decent performance status, but unfortunately has such high volume disease, they're not a great surgery candidate, and at some point or another, they're going to progress through chemotherapy or develop limiting systemic toxicities to the chemotherapy. And really the question was, is there a benefit to performing repeated laparoscopic HIPEC? The rationale for performing repeated procedures basically means we would perform a diagnostic laparoscopy once every month and then perfuse with intraperitoneal chemotherapy. These were outpatient procedures and they were able to go home afterwards. This actually originated from some data from MD Anderson, Brian Badgewell, who had kind of pioneered this approach for peritoneal carcinomatosis in gastric cancer patients. We just shifted the disease focus to colon and appendiceal patients. The advantages of doing a palliative type procedure like this are that it's novel. It potentially offers some symptom control benefit, both for malignant ascites. Potentially, could it delay their progression of disease and or prevent them from developing a malignant bowel obstruction? The procedure has low morbidity, and it also allows us to test tissue response to treatment as well and study some molecular correlatives. More recently, and something that I'm really excited about, and here in our last couple of 2 or 3 slides, we hope to implement and introduce here at UNC pressurized intraperitoneal aerosolized chemotherapy, HIPEC. This is something that's been performed in Europe for the last 10 years. It's taken some time to get the catheter and the technology FDA approved here in the United States, but recently it has. The rationale for performing HIPEC is that you perform these diagnostic laparoscopy procedures, but then administer intraperitoneal chemotherapy in a pressurized form through the trocars using the special catheter. You can see the injector here. This is just a normal venous injector that would be used in any angiography suite or any CT scan suite when giving a CT scan with contrast. It's the same sort of technology. We're administering the chemotherapy in a very fine, ultra microscopic aerosolized form in an effort to treat these patients. We know from preclinical, this is a large animal study, there is improved tissue absorption, giving HIPEC to the right. This is a methylene blue used as the agent when compared to HIPEC, as you can see here on the left. We also know that it has administration via HIPEC, pressurized, has reduced systemic absorption when compared to HIPEC given intraperitoneal. And you can see these results here. And lastly, we administer the pressure at about 10 millimeters of mercury. You have marginal benefit above. Just for sake of analogy, when we perform a normal diagnostic laparoscopy and we infuse the abdomen with carbon dioxide gas to blow the abdomen up, we administer to a pressure of 15 millimeters mercury. So it doesn't take a lot of pressure to get the aerosolized chemotherapy out. The first really to do this was Mustafa Roof, and he reported on this phase 1 trial with a specific catheter looking at the safety and efficacy of oxaliplatin, which is the preferred agent to administer HIPEC. It's administered more effectively than mitomycin C. So oxaliplatin is the chemotherapy agent that's used. They did a phase 1 trial at the City of Hope of 12 patients, administered 3 different cycles, and had a 12-month overall survival for all patients. 2 patients ended up being able to undergo a definitive cytoreduction in HIPEC, safe, feasible, efficacious, and multiple other centers, including ours, are now starting to look at this as well. So in conclusion, thanks for hanging in thus far. These patients are complex. and oftentimes benefit from a multidisciplinary approach between medical oncology, radiation oncology, radiology, as well as pathology. There's only about 100 centers in the United States that perform HIPEC regularly. We're very fortunate in the state of North Carolina. We have UNC here centrally. Duke, just right down the street, performs them as well, as does Wake Forest. But we need more surgeons. There's only about 200 of us. That ends up being about 4 across the state, and that's about right where we land as well. And certainly efforts like this, I really appreciate, because we're trying to increase the awareness. Certainly we want to help these patients and capture these patients who unfortunately probably many times have limited treatment options. They're complex. They have a significant learning curve. Palliative treatment options are available for patients with carcinomatosis as well, whether laparoscopic HIPEC or PIPEC, which is we hope to introduce soon for the treatment of malignant ascites and to hopefully delay the progression to malignant bowel obstruction. Randomized trials are difficult in this patient population. However, we haven't fared well in the United States, but there are certainly efforts to do this better. Europeans are much better at this as well. But multi-center collaboration will definitely be needed. So that's all I have for you today. If you don't have any questions, we can go to questions or...
Yeah, so why don't we go through these questions first, and once we get through these, then the audience, you guys can submit questions to Dr. Deneve, and we could go through those before we wrap up. So to circle back to our poll everywhere questions, peritoneal carcinomatosis is an aggressive form of disease spread and characterized by the following manifestation. So we have 100% advanced disease at onset, and then some are coming in at all of the above. And some might be changing their mind.
Yeah,
so.
That's just great. So very good. Carcinomatosis certainly, I would say, is characterized by all of these. Oftentimes very advanced disease. Ascites is a common presentation as well. Many of these patients are malnourished, even though they look okay. Oftentimes, the development of the disease, the metabolic demands, these patients are pretty malnourished. And if left untreated, a pretty significant portion, up to 30 to 40%, will go on to develop malignant obstruction. So all of the above is indeed the correct answer. Great.
Our next question, recommended treatment for malignant-related ascites includes all of the following except. And while we wait for some answers to come through, I appreciate you mentioning diuretics. I think when people have fluid retention, that's the first thing patients ask for, providers want to give them. And I think with ascites, it's hard.
I think this is, and that's part of the reason I actually included this slide when I was trying to decide, what would be important to your audience and what would you potentially see. And I think ascites is something across all of our disease spectrums that whatever your specialty may be, there are times you'll encounter a patient like this. And I think appropriately so, diuretics are the mainstay of management for patients with ascites. It's interesting to note that a small percentage of patients with ascites, that is their form of disease presentation for carcinomatosis. And in my world, that's primarily what I see. But it's important to note that in the absence of underlying liver disease, you probably need to look a little bit deeper. This is a little bit of a tricky question, and so I certainly appreciate everybody's looking at this. I think all are correct, and I included PV shunt on there really because we've moved away from that as a standard treatment for these patients because of the high morbidity and mortality associated with it. HIPEC and PIPEC actually are both indicated in centers who see a lot of this, such as ours, as appropriate therapy for these patients, and we're actually able to get this approved for treatment of the malignant-related ascites.
And then our final question, cytoreduction and hyperthermic intraperitoneal chemo offer potential cure for carcinomatosis. HIPEC is characterized by all of the following except.
Yeah, this one I think is a pretty interesting one as well, and I think wanted to give you just the take-home points for those of you who maybe had maybe only heard of HIPEC previously or had no familiarity with HIPEC as well. It is a beneficial treatment for carcinomatosis. Heat is definitely beneficial to the chemotherapy and has a synergistic effect. We're able to give a very high regional dose of chemotherapy. Maximum tissue penetration is 3 to 5 millimeters. It should be performed at those centers who have some experience. And unfortunately, it has a pretty long learning curve and is associated with pretty significant morbidity, all the more reason why it should be performed at a high volume center, if at all possible, with experience managing this malignancy.
So references are attached. And if you have questions for Dr. Deneve, please put them in poll everywhere. We have a few minutes to ask questions. So you mentioned the wallpaper reference for surgery. So I have removed wallpaper before and have not enjoyed it, and it takes an incredible amount of patience.
Yeah.
So I imagine you have an incredible amount of patience for a surgery like this.
Well, I think it's an analogy that anybody who's done home improvement can recognize. And so I mentioned it, and I'm glad that you actually brought it up. I think as far as a technical aspect and technical procedure itself, these are very long procedures, on average 8 to 9 hours. And so certainly patients are pretty selected carefully. And much of this is kind of back to a movie analogy, the Forrest Gump box of chocolates. You never really know what you're going to get until you get inside. So I fully try and inform patients as well as I can beforehand what to expect, but certainly don't know until I get inside. And sometimes we get actually pretty deep into an operation before I figure out I can't remove everything and we have to back out. That doesn't happen often, but in any event, much patience is definitely required. So they're great training procedures, certainly for the residents and the fellows as well. And at the end of the day, we're able to hopefully for some patients offer, potential treatment for those that historically have had limited treatment options.
So we had a thank you to you for your review and additional comment about someone undergoing.
Yeah, so I appreciate the comment to the audience member, and I appreciate that. I'll read this. Thank you for the excellent review of treatment for this disease. My husband died in 1999 at the age of 40 after his second surgery. His first surgery was in 1998. At the time, there were very few locations that performed these procedures. Dr. Brian Logie, who I know personally and is a very good surgeon, performed both surgeries. And I would say, I'm sorry for your loss, and it's your husband. That is the reason why I am here, and the reason why the gray hair is here and the bags under the eyes and everything else we do, because you realize you can't put a value on life. And to your point, there are very few centers who do this. There needs increasing awareness. And as we live longer as a population and older, we see more and more disease. And so certainly, and many of these patients end up undergoing multiple operations as well. Most of the time, and there are several nuances we could go into further, many patients have had 2 or 3 operations by the time they actually get to us. And so oftentimes that increases the degree of complexity. Patients do recur after surgery as well. Some of them are able to go back to additional chemotherapy, and some are able to offer additional surgery as well. I do think there is an increasing role for the management of stage 4 disease, however, and even for those that we can't cure, I still think there's a role for palliation as well, and I feel passionate about it because at the end of the day, your husband was 40 when he passed away. And I wish I could say he's the only 40-year-old that I've ever operated on who's done poorly, but he's not. And at some point or another, if you've got young children at home and you've got a lot of life ahead of you, but a really difficult diagnosis, months matter. And at the end of the day, I would want as much quality time, irrespective of whatever the quantity of time I had left. And hopefully in some way we're able to provide that for some patients. Also, I would say it's not just us that are performing the procedures. It's the nurses that are taking care of these patients, the ICU team, the floor nurses, the OR nurses, the anesthesiologists, the medical oncologists, the APPs, and everyone else who has some small role in their care. And I get to come to you and talk to you about these complex procedures and all the things we're able to do. But at the end of the day, I'm just a small piece of the puzzle. And it really does take a village for these patients. And historically, 20, 30 years ago, many of these patients would have been written off and referred for either palliation or to hospice. But I think we can do better. And that's why we're here. And so that's hopefully what we'll implement. And hopefully I've helped educate some of you today. So I certainly appreciate the opportunity to come. This has been fun and enjoyable for me. And so I hope fun for you as well. I appreciate your time and listening to me speak. And even though I tried to take out the Southern drawl, you get a little bit of it. So.
Thank you, Dr. Deneve, for spending the afternoon with us and sharing your expertise with the audience. One who cares for many patients that you mentioned in your talk. Grateful to have you here at UNC for your expertise and contribution to the care of these patients. So thank you to our audience. Thank you for hanging in there with us. Thank you to the University Cancer Research Fund, to the UNC Lineberger Comprehensive Cancer Center, the UNC Lineberger Cancer Network, and to our amazing telehealth team who makes all the magic happen, to Tim, Benny, John, Oliver, Andrew, Patrick, Lindsay, and Barbara. Thank you all for your assistance in our programs.